Welcome to part 2 of our tuberculosis review for Step 2. In part 1, we covered active TB, the right regimen, and special populations. In this video, we will master latent TB, who to screen, how to interpret PPD and IGRA, treatment regimens for LTBI, and the BCG vaccine. Let's get started. Latent TB infection, or LTBI, is a state where the patient's immune system is constantly responding to tuberculosis antigens, but there are no active symptoms, and the patient is not contagious. The goal of screening is to find these patients before they progress to active disease, because about 5 to 10% will reactivate in their lifetime. Who should you screen? First, every HIV patient, regardless of other risk factors. Second, patients starting immunosuppressive therapy such as TNF-alpha inhibitors, chronic steroids, or transplant medications. Third, close contacts of active TB patients. Fourth, recent migrants from high-burden countries. And fifth, healthcare workers, prisoners, and homeless individuals. The PPD skin test, also called the Mantoux test, works through delayed type hypersensitivity, a type 4 immune reaction. The procedure has 2 steps. Step 1. Inject 0.1 milliliter of purifying protein derivative intradermally on the volar forearm, which creates a small wheal. Step 2. Return in 48 to 72 hours and measure the diameter of induration, not the redness. Induration means the firm, raised area, and that's what counts. The test requires 2 office visits, which is one of its main drawbacks. Step 2 Pearl. PPD can be falsely positive in patients who receive the BCG vaccine and falsely negative in patients who are allergic or immunosuppressed, including advanced HIV. PPD interpretation uses 3 cutoffs based on the patient's risk level. Remember the 5-10-15 rule. A reaction of 5 millimeters or more is positive in the highest risk groups: patients with HIV, close contacts of active TB cases, organ transplant recipients, or other heavily immunosuppressed patients, and anyone with evidence of prior TB on chest X-ray. A reaction of 10 millimeters or more is positive in moderate risk groups: recent migrants from high-burden countries, healthcare workers, IV drug users, homeless or incarcerated individuals, children under 5, and patients with diabetes or chronic kidney disease. A reaction of 15 millimeters or more is required to call it positive in otherwise healthy individuals with no risk factors. Step 2 Pearl. The higher the risk, the lower the cutoff. This is the most commonly tested concept, so memorize it cold. The interferon gamma release assay, or IGRA, is a blood test that measures interferon gamma released by T cells exposed to TB-specific antigens. It has several advantages over PPD. Results are available within 24 hours. It requires only a single office visit. And importantly, it does not cross-react with the BCG vaccine. It's also more specific than PPD. Limitations include higher cost, the fact that it cannot distinguish active from latent TB, and sensitivity to sample collection errors. Step 2 Pearl. Choose IGRA over PPD when the patient has received the BCG vaccine, since PPD would give a false positive. Choose PPD for children under 5, where IGRA has lower sensitivity. So what do you do after a positive PPD or IGRA? The next step is always a chest X-ray to exclude active TB. This is critical because you cannot treat someone as latent if they actually have active disease, since monotherapy on active TB creates drug resistance. If the chest X-ray is normal and the patient has no symptoms, diagnose latent TB and start LTBI treatment. If the chest X-ray is abnormal, such as an upper lobe infiltrate or cavitation, proceed with a full active TB workup including sputum AFB smear, NOT, and culture. Step 2 Pearl. A chest X-ray is mandatory before starting any LTBI regimen, no exceptions. There are 4 main LTBI treatment regimens to know. The preferred regimen is 3-HP. Once weekly isoniazid plus rifapentine for 3 months, with pyridoxine. It has the shortest duration and best compliance. The second option is 3HR. Daily isoniazid plus rifampin for 3 months, also with pyridoxine. The third option is 4R. Daily rifampin for 4 months, used when isoniazid is not tolerated or when there is INH-resistant exposure. The fourth option is 6H or 9H. Daily isoniazid alone for 6 or 9 months with pyridoxine. The 9-month version is preferred in HIV patients and those who cannot take rifamycins. Step 2 Pearl. Always rule out active TB before starting any LTBI regimen, because single drug therapy on active disease creates resistance. The BCG vaccine contains a live attenuated strain of Mycobacterium bovis. It is routinely used in high-burden countries to protect children from severe forms of TB, like miliary disease and TB meningitis, but it is not routinely given in the United States. The main clinical issue is that BCG can cause a false positive PPD test, which is why IGRA is preferred in BCG-vaccinated patients. BCG also has a completely unrelated use as intravesical therapy for superficial bladder cancer. Contraindications include immunocompromised states, pregnancy, and HIV with low CD4 count, because it's a live vaccine. For contact tracing, test all close contacts of active TB patients. Symptomatic contacts get a chest X-ray and sputum testing. Asymptomatic contacts get IGRA or PPD screening. Let's review the classic Step 2 pitfalls for latent TB. First, a BCG-vaccinated patient with a positive PPD should have IGRA to rule out a false positive. Second, a negative PPD in an HIV patient does not rule out TB, because these patients can be anergic and produce false negatives. Third, always measure induration, not erythema. This is a classic distractor. Fourth, always obtain a chest X-ray before starting LTBI treatment, because if you miss active TB, you create drug resistance. Fifth, before starting any TNF-alpha inhibitor like infliximab or etanercept, screen for latent TB. These drugs can reactivate TB. And finally, memorize the 5, 10, 15 PPD cutoffs, because they show up on nearly every TB question. Let's wrap up the TB series. For screening, always screen patients with HIV, immunosuppression, contact with active TB, recent migration from high-burden areas, healthcare workers, and the homeless or incarcerated. For PPD, measure induration at 48 to 72 hours. Remember false positives from BCG and false negatives from HIV energy. For cutoffs, 5 millimeters in the highest risk groups, 10 millimeters in moderate risk, and 15 millimeters in healthy individuals with no risk. For IGRA, single blood draw, fast results, preferred in BCG-vaccinated patients, but cannot distinguish active from latent disease. For treatment, 3HP is the shortest and most commonly preferred, with 3HR, 4R, and 9H as alternatives depending on HIV status and tolerance. Always add pyridoxine with isoniazid. Finally, the classic traps. BCG plus positive PPD should trigger an IGRA. Always obtain a chest X-ray before starting LTBI treatment. Screen for latent TB before starting TNF-alpha inhibitors. And an HIV patient with a negative PPD may simply be anergic. Good luck on your exam.